I am really grateful to be joined by Dr. Ruth Brady tonight. Dr. Ruth was on a WhatsApp group with us. We were discussing Masseter Botox amongst the aesthetic clinicians, and it's fair to say that she dropped a bit of a bomb on us in terms of knowledge. And I really wanted to share it with you because there's essentially a lot more about the Masseter, which we all need to know. And if you're not trained as a dentist, and even this is even postgraduate stuff, isn't it, that we're talking about? But I found it so interesting, and I love it when my perception of things is shifted. And it's fair to say that Ruth did that for me with discussing some of the complexity of why we get Masseter hypertrophy. So thank you very much for joining us tonight, Ruth.
You're welcome.
And for agreeing to share.
Thanks for having me.
I wanted to start just by giving a kind of broad overview of Masseter reduction as we often talk about it in aesthetics, and then we will then lead in to the more complex stuff to really kind of help people understand how much more interesting it actually is than I thought. So the aesthetic component of the Masseter muscle is essentially it looks bigger. So if you have a bigger Masseter muscle, it is less feminine. And you'll even occasionally meet people who are wider at their Masseter muscle than they are at their zygoma, which is obviously the wrong way around. And you occasionally get this in very young people as well. So I've had consultations with young girls of age kind of 24, 25, wanting their lips done. And because they're trying to balance this proportion, I know Ruth's got some interesting cases we'll hopefully touch on of other aesthetic presentations for Masseter reduction. And sometimes it's not even that they ask for it, they come for an aesthetic reason, and then you realize they've got these enormous Masseters. And really effective in the people that it works. If you inject toxin into the lower third of the Masseter, you cause muscle atrophy. You get an initial relaxation. So I always say to patients at the 2-week point, it'll feel softer and spongier. And then after about 6 weeks, you'll get the atrophy, and you actually start to look more beautiful if you've got the aesthetic diagnosis correct. So really powerful in the right person. What I didn't know about is all the dental complexity that goes with it. But that's basically the broad overview of the aesthetics. In terms of injection, just to give you an outline, I often teach, what I teach, try and get it in focus, is that we treat the lower third. I know there's a diagram on the internet of drawing a line that kind of runs to the alar base, and then I think you're a little bit more likely to hit the risorius muscle and cause an asymmetry. So I like to treat the lower third of the Masseter if I'm going to treat it, which is the bulk of where the volume is usually anyway. So the question is, with all of that, in terms, we know how to get the results, but what's going on underneath? So what I thought is I would ask Ruth to give us a brief overview of the anatomy. So the dentist will understand the anatomy in way more detail than you generally have to do as a doctor or an aesthetic clinician. So I'm going to hand over to Ruth and for her to give us a brief overview of the fundamental anatomy. Then we're going to go on to the healthy physiology, how your jaw actually should work in health. We might discuss then a case study with patients. How do patients actually present for this problem? Then we'll discuss the pathophysiology, so where it all goes wrong, what's actually going on that causes these muscles to become more hypertrophied. And what I'd like to then finish with is the ideal patient journey. So I want us all to get better at handling patients in this situation. I might need to let the cat out. The cat's been locked in with me and she's going to meow. That's live video for you. But Ruth, why don't you tell us a little bit about the anatomy first?
If I can just do my little introduction first by just saying that it's probably, I don't think it's taught very much at dental school, because 5 years of dental school really has to be spent on all the other things, the practical side of restoring teeth and everything else that goes with it. So it's very much a taster is given at dental school, and it's left really to postgraduate education. And I do find that even some dentists don't actually particularly go on to do postgraduate work on the occlusion. I think it rather depends on if they're perhaps doing a more advanced restorative type of work. But I would also say that I think I was very lucky 22 years ago when I found somebody to teach me. And they were very hot on it in America at the time, less so in England. And they used to come over here and teach cohorts of us. And their analogies and the way they would teach it was fantastic. So really, it's aimed at, I can speak in these terms to patients and, of course, non-dental dental clinicians as well. Some of it is very much anecdotal. There's not a lot of evidence-based. Well, there will be more now, but you know, some dentists will have arguments between themselves, fun arguments about which camp they believe in, whether it's Dawson or whether it's Pankey, and we'll have a little bit like religion, you know, the same God maybe, but differences in the way it's approached. So an argument between a man dentist and a lady dentist, of course, the woman always wins. So these are my ideas, the way I put them into practice for so long, for 22 years. And I can't say that every fact is true, because some of it is anecdotal and is supposition as well. So I'm going to give it you as closely as I can to as people understand it. And what I will say is, you were just talking, Tim, about treating for the aesthetics, which is what a lot do. I believe it's one of the most commonly treated areas with toxin these days, which I didn't realize that it was actually probably about the most common. And I think a lot of people are being treated where they have no symptoms, so the clinician has no idea that they've got a problem. And they may have a big problem that is hidden, a little bit like the iceberg idea, that there's a little iceberg on top of the water, but actually what you don't see is the massive, huge piece of ice underneath.
Yeah, that's the feeling I got from you when we were talking, which was what I thought was usually relatively simple. If they had no symptoms, you didn't need to worry much about anything else. And you revealed that there's probably a load of interesting complexity underneath. And that's what I'd really like to convey to people. Exactly.
And the fact that the important thing is the fact that they don't have symptoms when they come to you, if they don't, or a clinician is not asking the right questions to connect up those symptoms, or if they don't have them, it's only because their situation at that moment in time is being tolerated by the body and not throwing them into painful symptoms. It takes one simple thing to fling them onto the other side, where they then become symptomatic. And if somebody gets that, connects it up with something that you've done, medico-legally, you could be in a lot of problems. And that's why I think you're wanting to dive into this more, because it's really to talk about safety of treatment, isn't it? And to stop people jumping into these pits by accident. So I'll start briefly with I will apologize at the beginning if it's a huge subject and I've broken it down into sections, and because it's multifaceted, sometimes you can lead off the path and mention something else that's coming back further round into the story. So I do have a few guiders here in front of me, so occasionally I'm just going to be leaning across, because I've kind of got a tracking pattern of which I think is probably the best way of explaining the whole thing and keeping in line with what the way you're wanting me to take it as well, you know, the schedule. So I'm going to start off with the teeth, with the anatomy of the masticatory system. I'm going to keep it sort of in non-dental terms as much as I can, but yep. One component to start off with is the maxilla. The maxilla.
I've got a scallop here.
You've got one as well, haven't you? That's right. I've got one right here too. The maxilla is the upper jaw, and it holds the upper teeth within a bone on top of the basal bone called the alveolar bone. But basically, the upper jaw is the maxilla, and it holds the upper teeth. We then have the mandible, which is the lower jaw, which also holds the teeth, in which case will be the lower teeth. I'll go back to the maxilla for a moment. The very back of the maxilla, just there, we call this the tuberosity. Sometimes, sometimes when some wisdom teeth are taken
that's
out.
Right back here.
Yes, if there's some fusing there, the maxillary bit of bone actually snaps off with it if it's thin. So that is the tuberosity. Now, on the lower jaw, we have the ascending part here is called the ramus. Mm-hmm. And it has two prongs on it. The front one is the coronoid process. The back one is the condylar process. And on top of it,
So one is the hinge point where it's connected with the bone. That's your temporomandibular joint. That's
correct. The other one has a more of a leverage point for muscles.
Yeah. So anterior point is connection of the temporalis muscle and probably some of the pterygoids as well.
Yes. Oh, yes. I'll come to that in a moment. No, I will mention the insertions to make it clear. But on top of the condylar process, which is the one at the back, there is a ball at the top. Some might think it's a ball and socket joint. It's actually a lot more complex than that. It's a sliding joint, but I'll come to that in a moment. So we've got the condylar process and we've got the condylar head. And in that point, we've got the capsule. So I will now move on to this joint. This joint comprises of a head, which is semi-round. It fits into a fossa, the eminence, and there is a capsule, and in between the head and the fossa, we've got a meniscus, or in other words, a disc. And that disc is held in place by an anterior ligament and a posterior ligament. So they sort of snap backwards and forwards like they're on elastic, so that they have a range of movements. Because this joint, actually, I'll come to the movement sort of later on in this meeting, but it starts off as a hinge, and then it's a sliding joint. On these cheaper plastic skulls, it's harder to show, but it actually starts with a hinge movement and then it slides and translates, and we call it a translating sliding joint, which makes it different from any single joint in the body. And it's a 3D working joint, really. It goes in a whole range of movements, which it has to, because it's actually fixed to the rest of the mandible. And of course, that's how we are able to chew and open our mouth in various directions.
It's interesting. So that the models that we have are actually, the way that they've constructed this, it actually takes away some of the subtlety of it, because this
completely.
You've only got a two-dimensional movement, but the reality is much more interesting.
Oh yes, in fact, in dentistry, when technicians are constructing crown and bridge work, for example, or any restorative work on a articulator, they use an articulator. The cheap ones just hinge. The very expensive ones, they undergo a complete range of movements, which tries to mimic. I say tries to mimic the human. Nothing can mimic what we are. You know, we all have our individual movements, and some will be smooth working and some won't, and we'll come on to that, because that's the whole point of this. So
I'm just going to chuck this cat out. I'm sorry.
Oh, okay. As long as my sausage dog doesn't start up.
Sorry about that. There's many factors that come in that I'm unaware of, but anyway.
It makes it real live TV. So let's get on to the muscles, because these are very important. There are two groups. There's your main primary muscles. So this is your temporalis, your masseter, your medial pterygoid, and your lateral pterygoid.
Yeah.
The three.
So some of those, I know most clinicians will be pretty aware of temporalis and the masseter. The pterygoids are probably an area that might be worth putting a bit more time into.
The pterygoids are incredibly important, because they are often the ones that start to cause you the spasm in the first place. If we go on about temporalis, most people then will know that the temporalis, well, shall I say, the temporalis, masseter, and the medial pterygoid are responsible for closing the mouth, elevating the mouth. The lateral pterygoid is responsible for opening it, but it doesn't really open it very much. It just starts that first part of the hinge process. Gravity does the rest.
Not particularly strong. You can test that.
Well, it's not strong at all, because it needs the accessory muscles, which is a group that I haven't mentioned yet, to actually help the jaw open under forced movement. So we've got the primary muscles of those four, three working to lift, to close the jaw, one working to to start the dropping motion of the jaw before gravity takes over. But when you really want to hinge it open and force it open, or even when you're singing and speaking, actually, there's a range of accessory muscles, which are the suprahyoid, the infrahyoid. They attach to the hyoid bone, and they keep the hyoid bone in place, and the larynx. And then we've got unrelated, but it's part of the muscles of mastication, is the buccinator. That just has a function in chewing, of pushing the food back into the vestibule, because in the case of somebody that's had a stroke, if they've lost that power on the cheek, the food goes everywhere and they have inefficient chewing because they can't push it back into the center. So
one more interesting fact I know about that, which is apparently it's one of the strongest muscles of the body in babies, because they suck milk with that muscle quite a lot.
Absolutely, absolutely. And in trumpet players as well. I was a trumpet player. It's very, very important with that. And of course, in cows, it's a lovely cheek muscle. It's a thick muscle too, that people like to eat. And then the final one is the platysma muscle. So the platysma muscle actually assists on the opening process with, once the lateral pterygoid has sort of unhinged it, then gravity and the platysma then play a greater role. And I think the supra and the infrahyoids, they come later on.
I do mention that when I treat the platysmal muscle, as it's an accessory muscle for both lifting the head, and also if you have COPD, it's well known amongst physicians that you use it to breathe with. It's an accessory muscle for breathing as well.
All right, now I didn't know that.
Yeah, so it's interesting from the dental perspective that it's an accessory. I didn't know it was an accessory muscle for opening the mouth. So
remind me later on to mention that, because you do use toxin in that, and actually that can also unbalance a little bit the rest of the masticatory system. I did a test on my own a few weeks ago, and it works out fine, but in those first few days of actually doing that, I didn't like the change in pull that was going on. I was very aware of how it actually did connect with everything else. So that's something else that's worth, but remind me later on, Tim. I'll not digress right now, but that is something that's quite important. So just going
just come to get the cat out, but it's already gone. Sorry.
So those are the, obviously then we've got the teeth. So I've mentioned the muscles, we've mentioned the jaws, finally the teeth. People just think teeth are teeth, they're there for chewing, and they look pretty when you're smiling. They have a system within themselves, and they should be, in an ideal world, the anterior teeth, that is the incisors, which are the cutters, and the canines, which are the tearers. Those anterior teeth should actually protect the posterior teeth in function. So there's something called anterior and canine guidance. And if you have got a proper working system, then any excursion, and an excursion is a movement forwards, sideways, backwards. It's any range of movements that jaw makes. The anterior teeth should allow the lower teeth to slide down the palatal fossa, the shape, it's the way they're shaped, and it will come down the palatal surface, and at the same time, it will actually cause disclusion of the back teeth. In other words, number 4, the first premolar, right back to the wisdom tooth, number 8, so 4 to 8, top and bottom, both sides, should open up and not touch. And the important thing there is teeth have got cusps on them and they interdigitate. And when you have forward and backward movement, you do not want these going bumpety, bumpety, bumpety over each other. You want them to have some clearance. And that's very important.
I can see that even on the skull, I can see that movement.
Because they will have made that skull so it's got anterior guidance. The big problem is that many people's dentitions are not set up like this. They don't have that system. This is why there's such a lot of problems with people breaking teeth and grinding teeth, etc., which is where parafunction comes in. So the nerve supply, I'll come back to that. I'm really just giving the outline at the moment. The nerve supply, by the way, of the muscles of mastication, if anybody's interested. It's the fifth, the trigeminal nerve for the four main primary muscles, and in fact the hyoid, the infra and suprahyoid, but the platysma and the buccinator are both supplied by the facial nerve, which is nerve number 7, just to complete the anatomical picture. So we won't go into blood vessels. It is really not an issue at this point. So that's giving everybody an outline of the anatomy as such, but I do feel that I ought to now come in a little bit more detail on the individual muscles, really only the 4 primary muscles that we're talking about. So most people will be aware that the temporalis muscle comes from the temporal fossa, from the fossa right down to the origin, down to the inferior temporal line. And it's a fan-shaped muscle that works in 3 vectors. It's got a horizontal component, a vertical component, and it's got an oblique component. So
that's quite interesting. So we've got some of the fibers are coming from a different angle, so they're able to do, you're able to use different components of the muscle to slightly shift the direction of force.
Exactly.
Yeah. That's interesting, and you can actually see the striations of that when you look closely at a temporalis muscle.
So that actually in its vector pulls, you know, you've got the better purchase coming from whichever direction that you need it. It might be a wide muscle to start with, but then it comes in towards, it converges into a tendon, and that tendon goes and fuses onto the coronoid process. If you want to show that on your...
That's this part of the joint, this little bump over here.
Yes.
Yeah.
So actually, the action when it contracts that it allows to happen, it both elevates the jaw, which means it closes the jaw, but it also has the power to retract the jaw as well, if you were going to try and move your chin backwards.
Yeah. So I can see that really nicely. You can see how that would track underneath the zygoma and connect on the coronoid process. And also by thinking about those directions of muscle, you can see how it could be involved in shifting this in different directions, which is interesting.
And you'll often notice that with somebody with hypertrophy masseters, they've often got a hypertrophied temporalis muscle as well. And with somebody with no hair, you can often see that flexing even when they're chewing. So, going on to
I'll throw in another nugget while you're here. Those hypertrophied muscles can be associated with bigger vasculature around there, and it could be slightly more risky with dermal filler in the temple if they've got big muscles. Not that you're probably a bit less likely to treat them, but it's certainly known that the big muscles need a bigger blood supply, and you might just have more vasculature there.
I'll also throw in something else as well, that I think that a lot of the nerves and blood vessels that run sort of through the pattern of the path of the muscle, you know, sort of held in by the SMAS, if you've got spasm of that muscle, then you're actually getting impingement and squeeze on the blood vessels and the nerves. And this is where I think, digressing slightly, but I think this is where there's a real confusion in symptoms from people when they think they've got a migraine. I use the term loosely, a migraine from sort of intracranial dilation of vessels, you know, and whatever, to the outside. Often that nerve pain, that dreadful sort of almost lightning pain, I think is the masseter squeezing onto these, and therefore the symptoms are very confusing, and obviously you don't get the aura, but it is just a point to note.
Interesting. That's a whole new possible mechanism of headache. Yeah. So. Oh
yes, I mean there's a massive classification of headaches. My brother actually has done a book on pain. He was a pain consultant, and you know, there's a huge section on that. But that's another story for another time, perhaps. But going on to the masseter muscle. The masseter muscle is a rectangular muscle. It's got 3 sections really. It's got the superficial, which is what you palpate. It's got the intermediate, and it's got the deep. Its origin is the
deep is quite short, isn't it? Like the main one we feel goes all the way from the zygoma all the way to the gonial angle.
Yes, that's right. It's
and then underneath that there's a shorter component.
Exactly. Its origin is on the zygomatic arch, and also the anterior 2/3 of the zygomatic arch and the posterior bit of the zygomatic bone. So that's the origin, and it comes down and it attaches onto the outer surface. It's got two attachments really. It attaches onto the outer surface of the ramus of the mandible, but it also attaches onto the condylar, onto the coronoid process as well. So again, in order to get some leverage, because the function of this muscle is also to elevate, which is to close the jaw. It's also to retract the jaw, but it also has a protrusive action as well. So the jaw can go backwards and forwards as well as up. So that gives you an outline on that. And obviously it's a very strong muscle, and it's subject to hypertrophy, which is the whole point of this webinar or this Instagram.
Are we likely to hit the deep masseter with an injection in the lower third of the entire structure, do you think? Would you hit the deep masseter, would that be spared?
Well, it depends really on how thick the muscle is there, because, you know, if it's a very thick muscle and it's had a lot of hypertrophy, if you know, obviously there's a certain spread of the toxin. If you only go in at one point in a very thick muscle, then you may get relaxation of the muscle at one part of the thickness, but actually it doesn't affect the whole thickness of the muscle. So you may then start to get the contraction becoming a little bit bumpy and uneven. So sometimes if somebody's very, very thick, you almost need to bring the dose on its way out so that you go in deeper as you start deep and then actually come out a little bit. But you want to be careful not to be injecting too superficially, because you've got the rosaurus muscle that goes across, which is the one that makes the smile go, that fake smile that goes straight across. And you could get toxin filtering off into that. And that actually is one of the problems, one of the causes of giving you an asymmetric smile. Or if you won't go and do it both sides, you find that the person has a limitation of smile. So I'd always go in deeper and towards the middle of the muscle rather than the superficial part. Actually, I never inject too superficial. So I go and find bone first of all. But it's all dependent on the thickness of the muscle.
So this is the rosaurus is relatively superficial. I hope I've got it in the right place on this model, but it runs into the more superficial plane, and it's kind of mixed in with those superficial fibers of the masseter. So you're saying make sure you're deep. That's one of the ways of protecting the rosaurus.
Deep or intermediate to the muscle, but not into the superficial.
Okay.
The medial pterygoid is an interesting one. It's got two heads generally. It's very difficult to dissect, so nobody knows how many people have got the third accessory head. The two main heads, you've got the superficial and the deep. And their origin is, this is the third one that has the closing action on the jaw. The heads actually go from the maxillary tuberosity, which is that little bit of the maxilla behind the wisdom tooth, that curve of the bone there. One head attaches there, and the other one attaches on the medial side of the lateral plate of the pterygoid plate, which is on the sphenoid bone. So I have marked, I don't know if you can see it there, but right in there, can you show them on yours, Tim? It's basically attaching just behind the maxilla, but there's a special little plate for it called the pterygoid plate. And that muscle comes down inside the ramus of the jaw, and it attaches, if I hold my skull like that, can you see that blue area there? It attaches on the posterior lower border of the mandible, almost on the angle there, and it's just above the geniohyoid line. There's a little groove on the inside.
Yeah, I can see that.
So that one has an interesting action because it elevates, it's the third elevator. It also allows protrusion, forward movement of the mandible, but it's also got a lateral component in it as well. So the way is one of the muscles that allows the jaw to do the grinding. That this is why it's such an important muscle from what we're talking about, because it works ipsilaterally with the lateral pterygoid on the other side, which means that if they've both got two bellies, you've got the lateral pterygoid on one side works with the medial pterygoid on the opposite side to bring about one range of movements one way. And then to actually get the jaw to move the other way, you've then got the lateral on that side with the medial on this side contracting. So that's how they work. They work in opposite pairs. And it's a muscle that you can very easily palpate in the mouth to see. And it's almost the key sign that you have got spasm or you've got a malfunctioning going on. This final accessory head is quite interesting. You don't see it in some of the literature, but they're not quite sure what its function is, but what it does seem to do is it causes a little lateral shift of the condylar head at the final part of closing. And it's actually thought, because it does that, that it's one of the things that's responsible for causing a cusp clash in a wisdom tooth particularly, which is one of the, I'm going to say, call them later on, interferences, the spokes in the wheel, that stops the mechanism of the mouth and the chewing surfaces working properly. And it's thought to be the one thing that triggers off a spasm. So that's quite interesting. I'm going to pose a question here, and I don't know the answer. I don't know if anybody knows the answer. But since there's a certain proportion of the population who've got this accessory muscle, but some haven't, because this is, an anomaly, are the people that exhibit more clenching and grinding particularly, and this is triggered off by these interferences, is this one of the things that maybe goes along with that section of the population? In other words, are the worst grinders and clenchers, are they people who happen to have this accessory muscle? I haven't got an answer for that, but logically, it seems quite a good stab at an idea that, why not? It's obviously one of the factors that comes into play.
So I had a thought while you were just talking also about that clash with the wisdom teeth at the back, is the sensitivity of the teeth. I remember one of the first dentists that I mentored taught me a lot about teeth, and I remember him saying that you can tell, even the width of a hair, you can feel that, and we all know that if you have a hair between your teeth, you can sense that.
It's the proprioceptive system in the ligament space that the tooth sits in. The tooth sits in a socket in the alveolar bone, which is the bone that sits on top of the base bone, the basal bone. And it is so sensitive. It's almost like a trampoline with many, many ligaments and filaments and sensory endings. And even a hair caught between your teeth, if you were flossing with a hair and you just left it there, you would feel that. That's the proprioceptive system. That's very, very important to what I'm going to come on to tell you later, because it's far cleverer than we are. It's almost, it goes into then subconscious, the neuromuscular pathway. So finally, I'm just going to
I was just thinking that, it's no surprise this is going to be complicated, because we're really dealing with something that evolutionarily is the most important thing we do, eat.
Yes, exactly,
So,
exactly.
It's really, really finely tuned. So it's going to, be interesting.
Just digressing here. I just have I have one little theory that, the numbers of people that are treated for acid problems, stomach problems, etc., etc. I often wonder how often the medical profession actually look inside the masticatory system, inside the mouth, to see if it was a combine harvester and the corn was being ripped off and it wasn't being sheared properly. and there was a problem with the whole yield, the first thing the farmer would do is look at the cutters on his combine harvester. If they were half missing, he'd realize that was the problem. When you think of the population that have got poorly fitting dentures, they have no back teeth. I wonder sometimes about the food bolus and the chewing, how much that affects, because that's supposed to be the first part in the masticatory system, is to mix it with the enzymes to get a certain amount of breakdown before it's actually swallowed. So it's I just thought I'd put it in there, but it is an
I wouldn't be surprised
idea.
it had made a difference, because these small differences in machines make incremental impacts, so that they're kind of this cumulative effect, which is also why we need to be careful with our aesthetic interventions, because what seems like something that has no side effects might cause something subtle down the line, which is our fault if we don't understand it properly.
And in terms of painful symptoms regarding the masticatory system and linked to headaches, it can be a massive problem to the patient. In fact, it's what I call the central computer. If that's ill, if that's earache, toothache, headache, jaw ache, then you really can't function. Whereas if you've got a sore finger, you can sometimes just sort of stick it under your arm and sort of comfort it. But the central computer, it really does throw your day out or even your week. The final muscle I ought to talk about is just the lateral pterygoid. The lateral pterygoid is the only one that actually opens the mouth, but it doesn't fully open the mouth. It really is only responsible for that initial unhinging motion before gravity takes place. It has two heads, an upper and a lower head. Its origin is in the infratemporal area. In fact, it's the main muscle of that area. It actually interlocks like this with the medial pterygoid, because they are working very much together and ipsilaterally. And it comes off the pterygoid plate, but the other side of the pterygoid plate. And it also comes off part of the sphenoid bone there. And it locks into what we call the fovea on the head. There's a little divot on the head of the condyle. So you've got the condylar process here. And it actually locks into that by a tendon. It also locks onto the capsule, and it also locks onto the meniscus. And that's very important. And I better just describe a little bit of the working of the jaw joint, because this is in the case of TMDS, temporomandibular joint dysfunction syndrome. This is I suppose the jewel in the crown, if you like. It's the epicenter. So its most relaxed position is when it goes into it slides up a ramp into the joint, the socket, which almost looks like a ball and socket joint, but it isn't. But then it actually hooks forwards a little bit. So that's its actual correct resting position. And I think that the lateral pterygoid just unhooks that little position before it then slides down. And what it does when it slides down, you have a disc that rests in between, so you don't break bone like you do anywhere else, any other joint. And that disc actually has elastic tendons either side, and it travels with that slide, with the condyle head that's going down that sliding fossa. It goes down, and then when it closes, it pops back up again. But it should do silently. And if there's a problem with the joint, if there's spasm in particularly the lateral pterygoid muscle, you can get forward pull on that disc. If you've got spasm in that muscle for any period of time, a long period of time, you can actually have that disc pulled forward of the apparatus, which can lead to dislocation, a jaw that's locked open, or even a jaw that's locked shut. So there's one other interesting thing about that muscle. In people who clench too hard, they have a severe clenching problem. That muscle, although it is actually a muscle that drops the jaw, that starts the drop of the jaw, it has a protective element in it, which stops that jaw joint being pushed too far back by the other muscles, like the masseter muscle. and driving it into the postcondylar apparatus, which we know is the ear. So in other words, that muscle, although it's something that pulls the jaw down, it's actually got a little element in it that stops the jaw being rammed backwards with the force of clenching and protects the ear. So it's an interesting, it's working in the opposite direction there, but I think that's because it's hooking it back up. So going back onto the program, the way you were wanting to run things, I've really gone through the anatomy there of what we need to talk about as a background. Can I now go into the sort of the healthy physiology, the story of really what's going on in the engine? And I will describe this in quite a nice analogical way, in the sense that I'm now going to talk about if the teeth, if the mouth, the masticatory system, the jaw was a car. At dental school, largely, you are taught to work on the bodywork of the car so that it's all beautiful, straight, gleaming, shining, and attractive. And so the teeth are the teeth is the bodywork. The postgraduate part of the whole subject really is the engine. But, you know, what good is a car that it may look absolutely aesthetically beautiful, but what if it has square wheels? Or what if it's got overhangs of metal, spoilers that actually interfere with the workings of the wheel? You'll have a nice car sitting on the drive, but it doesn't go anywhere. The moment you try and start it up, it bumps along or it doesn't even drive forwards. Mm-hmm. And so
this is this just for there are a few, you can see more people joining. This is for specifically for how this then impacts on causing master hypertrophy, which we're going to come on to next. Just want to make that contextual for those people joining.
So we've really got to consider the engine, and the engine is the musculature. That's what's driving the jaws. That's what's altering the position. The engine has got to work in a smooth pattern, knowing that the teeth, they're not flat. The teeth have cusps on and they interdigitate. So I would also say that the normal structure of the jaw with a masseter muscle, which you're noticing from an aesthetic reason, is within the realms of normal size. And one has to say, what is normal size? I would say normal size is look at the rest of the body. If that person's a very lean, muscular type of person, they've got strong muscles anyway. They're a strong, fit, healthy individual. They may have bigger, stronger masseter muscles than a weaker, more delicate individual. So I think it's not the size per se, but it's the size that fits with the face. And that size is there by the fact that it's undergoing normal function. And normal function is that it's a smooth working engine with a smooth working bodywork. They're totally harmonious, and the action together is harmonious.
Yeah, that word harmonious comes up in aesthetics a lot, because I think that's what we're seeing in beauty is a harmonious system. So that's what you're seeing when someone isn't beautiful. There's something, this fits really well, that it's not just randomly a bigger muscle. There's some disharmony in the system. I like that idea.
That's right. So once you see a muscle that you consider is over large, then we call that, it's undergone parafunction. And I would say that parafunction is any function that is aside from the normal function. Whether it be something that you're doing in your sleep or something that you're doing while you're awake.
So it's not speaking, and it's not eating, or maybe a little adjustment, then you're doing something additional it's, I mean, parafunction makes it sound like it's obviously running in parallel with normal physiology, but it's also pathological function, would you say? Is it fair to call it that?
Well, it's very interesting. It's very easy to tell, really, because actually your teeth are only designed to touch for about 12 to 17 minutes a day. And people will think that's extraordinary. That is normal function. Now, what adds up to 12 to 17 minutes a day? They touch at the end of a chewing stroke, not all the way through. They touch at the end of a chewing stroke for milliseconds. The proprioceptive system that we were talking about earlier, the moment it hits something, it springs open. You can tell that, how fast that happens by, if you hit a granary pit, you've sprung open before you've even thought, oh, I better spring open. It's just happened absolutely automatically. But the other thing is, when you swallow, if everybody watching this program now, or this Instagram, wants to just swallow, as long as you've all got back teeth, which I assume you have, you will notice that you touch just momentarily. So we swallow about 2,000 times a day. Let's say we have 4 meals a day. The end of a chewing stroke, normal function is touching of teeth. It's adding up to about 12 to 17 minutes a day. Some poor nerd somewhere has obviously done some research on this and counted all up these milliseconds up.
It's a very small number. I am surprised by that. That changes your thinking, yeah.
But that sort of function does not cause damage to teeth. It doesn't cause wear to teeth. So when I mentioned later on that teeth show wear facets, you don't get worn teeth through normal function. So anything that's other than that, if it's not a fracture from something, an extraneous problem, then it is actually parafunctional. So anything that causes excessive function from that, whether it be daytime, and I'll give you some examples of daytime, it could be deliberate gum chewing, stress breaker, like football managers on the side of a football pitch in a match, chewing away. It's a stress breaker. They're doing it because it's actually a stress release for them. The other things might be that they are driving in the car. There's nobody speaking with them, so they're perhaps late for their appointment and they're driving under tension and they're locked up. Another time might be an exam. You've got your head down, your jaws are locked up, heavy periods of concentration. So gum chewing and heavy periods of concentration, or weightlifting at the gym, pulling on the upper body muscles, which is making you contract the platysma and all the jaw muscles. So that is a daytime sort of parafunction, but it's not huge periods of time. The main parafunction is at nighttime, while you're asleep, and it can be that the teeth are literally locked together for about 5 hours during deep sleep, 5 hours a night, unless you sleep on your back, but a lot of people sleep on their fetal position. So that is where the majority of problems that you see and wear and fracture on teeth occur from. And so when we talk about parafunction later, I'm going to also subdivide it into, there are 2 different types of jaws. Well, there's more than 2, but loosely speaking, there are people who have a shallow overbite. That's where their front teeth, a little bit like the skull, the front teeth only just come over the lower teeth, the upper front teeth come over the lowers. And then there are people who have a deep overbite. So people who have a shallow overbite, or indeed virtually no overbite at all, they're almost edge to edge, or even worse than that, slightly open. When they lock up, they actually, as they go into excursions with the jaw, they have the ability to go and move across those teeth. And if they've got a good guidance, which is what I talked about earlier on, where these slopes on the front teeth allow these teeth to slide down them in a protective manner, thereby taking the back teeth out of contact. If they're lucky enough to have anterior guidance, they don't usually have any fracturing or wear at the back. On the other hand, I should say that there are a smaller number of people who are lucky enough to have that system. Most people will have a system that is non-ideal and has spokes in the wheel. It has interferences. Now, an interference is a cusp, a bump on a tooth that clashes with another during an excursion being a movement, be it forwards, or sideways, or a range of that. The jaw should be able, if it was a good car with easy running wheels, it should be able to freely glide wherever it wants without any damage to the back teeth at all, using the front teeth to assist it as their guiders. But in most people's, I would say a huge proportion of people, there are interferences at the back, so that when they move their jaw either forwards or sideways, something at the back clunks and clashes and bumps over itself. And that's what we call an interference.
Mm-hmm. And
so,
is it particularly significant that it's at the back rather than the front? I mean, or...
We are a class 3 lever system. So at the front of the mouth, there's very little force. At the back of the mouth, you'll be surprised to know that you can actually put on forces of 20 stone per square inch. That's a huge force. That is in kilograms, about 130 kilograms per square inch.
Everyone's testing it now.
So
yeah.
so as the jaw goes along, in normal function, this is not a problem. You might occasionally just bite on something and just hit a cusp at the wrong angle. But generally, because you're only touching at the end of a chewing stroke, this is not a problem. And during the day when you're upright, we have something called a freeway space in between the jaws. So as you're sitting listening to me now, Tim, there will be a gap between your teeth, because when you swallow, you'll bring them together and then you'll spring open again. Even though your lips are together and your mouth looks closed, I know for a fact that your teeth will be slightly apart. So that is the freeway space. It's at night time, when you go into fetal position, that freeway space disappears and your lower jaw will more than likely lock up into the upper jaw. And the teeth will interdigitate. Now, I'm going to go on to another thought here. Hold that thought for a moment, because you'll get them all, they'll all come together, I promise you, by the end. The jaw, the lower jaw, is a rigid structure and it has teeth on it. The maxilla, the upper jaw, does not move. It's fixed to the skull. So the jaw that does all the damage is the lower jaw, because that is the one that is moving.
Makes sense.
Teeth, that's right. The teeth that sit on the lower jaw, those, sorry, I've just lost my train of thought just then. Just let me get this back. The lower jaw is the thing that is actually doing the motion. Sorry, I've just, we're wanting fluency of movement in all excursions. Sorry, something just distracted me across in the room, and I've lost my train of thought here.
Someone's asking on Instagram. Well, someone, Berry Dental, who's thrown in lots of useful information, is saying a tripod. I don't know if that's related. Is there a tripod component to how it's working? Like,
in a sense, the jaw can come down. It can sort of unhinge more on one side, but it's not a range of movement that we would particularly talk about. No, I've lost my train of thought now on, sorry, I do beg your pardon. The lower jaw is the one that moves. Therefore, right, I've got it back. Okay, we've got an argument going on, and this is the crux of the whole matter. We've got the teeth are sitting on the moving vehicle, which is the lower jaw. Sorry, I got distracted. My husband just moved into another room and it distracted me there. So that's right. Okay, I've got so many analogies here, they've all got to fit together. Okay, the teeth have cusps on them, unless they've been ground flat already, and early teeth, young teeth will have cusps on them. And it's a little bit like the joint itself has a favorite position, and that is when it is in its fossa, in its most anterior superior position. When it's in its anterior superior position, it is rested because all the muscles, the 4 muscles that attach it in place, they are actually at rest. And this is where I would like everybody to participate, because it's a good demonstration, and including you, Tim, if you wouldn't mind.
Yeah, I've been clenching and moving my jaw all the way along.
I'd like you all to put your arms in the air. Please humor me.
Oh, this one.
Keep it up there for a period of time. I will let you let it down, but I don't want you to take it down if you get tired. Just leave it there for a little while, because it's the best demonstration. So if everybody's watching, please humor me here and put your hand in the air and just leave it there. The jaw joint, when it is surrounded by relaxed muscles, which is ideally what you want, that jaw joint has to be in one particular favored position. What's stopping that jaw joint being in that favored position? Well, on the rigid jaw, there are teeth, and teeth have cusps. Think of them as a cone. Fingers in a cone, teeth in a cone. There will be an argument because the teeth always want to go to a position where they interlock at what we call maximum intercuspation. They will not be comfortable until they have moved into a position where they are at their most stable and the jaw rests more stably, one jaw in the other, by virtue of the teeth. But it's actually also attached onto a rigid structure that's got the jaw joint. So the teeth will win the argument every single time, and the jaw joint will have to accommodate the position of the teeth. So if that means that the jaw joint's got to be slightly further back or slightly higher up, but not as far forward. Now I know you're all wanting to drop your arms. Drop your arms. Why did I make you put that up? In fact, every single joint in the body, even the finger joints, everything has an optimum position at rest. Your hands are not at rest. The muscles in your hands are not at rest when your hand is straight. But if your fingers are slightly curved, those muscles will be relaxed. It's exactly the same for the rest of the skeleton. If you consider a skeleton, an entire body made up of wire coat hangers, and it's in a perfect balance, and it's held together by elastic bands, from one coat hanger to another coat hanger, all the way down from top to bottom. And you've actually managed to balance them in a perfect equilibrium so that every single coat hanger is balanced and every single rubber band is also not under stretch. But is relaxed.
So it's effortless in that position of equilibrium.
Exactly.
Yeah.
The moment you adjust one coat hanger and you put one lot of elastic bands under stretch, if the thing isn't to collapse, another one on the other side will have to go into stretch to rebalance, contralateral. And so that will then have another effect on another, and it will ricochet right down the coat hanger structure or the body until everything has found a new equilibrium. This is exactly the crux of the whole point. Because if on the jaw with teeth, the teeth have won the argument and they have said to the jaw joint, I don't care where you want to sit, we want to sit in this position. So you're just going to have to tough it out, and you'll have to accommodate in whatever position you can. So in other words...
Sorry, I've just got to interrupt you because I'm about to lose the Instagram feed. I'll go back on again because it only gives you a limit. So I'll pop, if I can, I'll just restart that. But sorry, carry on.
So, of course, what this means in real terms, if most people have got a non-ideal dental system, and just because they've had their teeth moved by orthodontics and they look pretty and they look a very aesthetic arch, that does not mean that they have a good working system. In fact, some crooked teeth could actually have a better working system than some of the beautifully orthodontically moved straight aesthetic teeth. So don't be fooled by the shape of the dental arch. If the teeth have won the argument and they have actually settled at night and interdigitated into their most stable position, the jaw joint, the chances are, will not be in its optimum position. If it's not in its optimum position, extrapolate that back. One or other of those 4 muscles holding it in position will actually be under stretch, and that will be really the pterygoid muscles. And if one of those bellies of the pterygoid muscle is under stretch, then another one is going to be under stretch or contraction to counteract it. And so if the medial is, the lateral is. And so you can now see how the whole system comes in, because the pterygoid muscles are the things that actually adapt to some of the lateral movement. So there's going to be a shift in position. And particularly, if you remember, I told you about, with, say, wisdom teeth at the back, that medial pterygoid, if that has an accessory part or goes into contraction, it can start to cause clashing of these cusps, which maybe were interdigitating very nicely. So you start to get an argument going on, a readjustment with the muscles, and it's now become a neuromuscular pathway. You're asleep, you don't know anything about it, and you don't give a damn. But unfortunately, the brain does. The brain knows jolly well that the condyle is not where it wants to be. So it's now giving a message to the muscles, and it's telling it in simple terms to start to do something about the teeth, the interferences, the teeth position that is actually stopping and preventing that jaw joint from being where it is. And so this is where grinding comes in. Now, this is a hypothesis that we go by, that it's the neuromuscular system like this. But really what happens is you go to sleep at night, you add a bit of stress into this equation. We know that it's certain type A characters particularly that suffer with this problem, with upper body stress, the whittlers, the worriers, the OCD, the ones that like the house so immaculately tidy. They're very much into straight lines. They have a very low tolerance. I don't mean they're not tolerant people to other people, but they have a very low tolerance level within the masticatory system. And they are the ones that cannot stand the fact that the jaw joint won't sit where it wants to. So it sends a message to the muscles, and the muscles start to work as if to flatten off the teeth, because the cusps on the teeth are interferences.
That's really interesting. I like that idea when you explained it to earlier, that it's it's a hypersensitivity to, well, that you get a type of neurology essentially that is sensitive to imperfections, and then it works to try and solve it while you're
absolutely. And laid back people don't tend to suffer in the same way. They don't seem to get the painful symptoms in the same way. That's my findings after 35 years in dentistry, that it seems to be very much linked to character type.
So that's interesting. Could you see something physiological, or something, you can see something in the mouth that would indicate that they have the problem, but they don't have the symptom set? Does that happen?
Absolutely. Yeah. And I will come on to what those are in one of your questions, which is to how to tell that. So extrapolate it to the fact that, just imagine an idea where the teeth have been ground flat in somebody that, this does happen, of course, we do see it, and throw into it that this type A character is a worrier, a whittler, and often along goes with that the fact that they get acid reflux. They're often people who suffer with acid reflux. So they lie down at night, they've got acid in the mouth, they're grinding, the muscles are grinding, and the teeth start to wear, and you start to get flattened facets. And you also get flattened facets and change in shape on the anterior teeth as well, because the guidance isn't working very well. So they really are destroying their own enamel. The lower jaw is becoming a very destructive machine. If they were to destroy the anatomy, the anatomical occlusal surface of the tooth, and make it completely flat, the jaw joint would possibly be delighted, because it would actually have no interdigitation. It would have nothing there to win in an argument against it. And so it would be able then to go and sit in its most anterior superior position. Who knows then, perhaps the muscles would be a lot more rested. And
yeah, I was wondering about that. Like, how long would it take to actually wear down an imperfection? You'd think that if you're doing it a lot, that you'd eventually create a more perfect mouth, for want of a better description.
I think it depends on the size of the person, the size of the teeth. Are they an acid producer? Do they have, what sort of forces do they have with them, with the muscles anyway? So how long is a piece of string? That's hard to say. All I know is I don't work as a dentist anymore. I do this side of things, but I just work in aesthetics now. But in the 35 years that I worked, I saw people in their 30s, even younger. Well, actually, no, I even saw teenagers with marked wear facets. That was often linked with acidity, and I would send them off to the GP because I'd know something else was at play. But it could be people in their 50s, all the way through. They're going through a slow process of attrition, pestle and mortar attrition on the dentition, which is why I've got a splint here. But this is something that we actually we try and assimilate a flattened dentition by popping this into the mouth, and I will demonstrate.
Yeah,
it's in now, and my jaw can go anywhere. There are no interferences there at all.
so that's to stop it catching. Now, so I've used one of those for teeth whitening before, and it's really interesting what you're saying before, because I want to chew that thing the whole time. Whenever it's in, I find myself biting on it. Presumably it's not.
That's because it's a different design, because when you have something in for bleaching your teeth, you've actually got a sort of class 3 lever system, and you are actually wedging. If you've got the upper and lower in together, or even the lower, you're actually wedging at the back, and you're giving even more contact at the back. So it's actually making the situation worse. So either a bleaching tray, or indeed a soft appliance that some dentists do give to start off with, for somebody to try, they actually can be, in some cases, worse than useless. They may just be a bite-raising appliance, something to give a patient a little bit of relief for a while. But really, something hard like that has a ramp on the front, so that I am actually giving the jaw guidance at the front, so that when the jaw travels forwards or sideways, it goes down a ramp, which opens the mouth, which takes the back teeth out of occlusion. So the fact that you saw me moving my jaw any which way I wanted just then, almost like a smooth piston, was because I had taken any interferences out of this scenario.
Yeah, I get it. So I'm actually looking back at the skull, and you can see there's like a millimeter gap on the back teeth, and then they occlude towards the front, which is what you've been talking about.
That's right. And
that device that you put in essentially guarantees the space at the back.
Yes. Well, yes, it does. And you can either have a device that has no contact from the premolar to the molar, so number 4 to number 8, and just has them resting on the front ones, or you can have it where you've got a perfect even arch all the way around, but the moment their jaw starts to move forwards or sideways, then the front teeth take it down a ramp and the back ones disclude. So it takes away the it stops the neuromuscular pathway really to the brain, telling them that there's an interfering problem in the system. So that gives you an idea really of what's the trigger point. Now, when we talk about wisdom teeth, we do believe that a lot of people who end up with parafunctional habit from nighttime grinding and clenching, they will often have one or more wisdom teeth in place. And we do believe that the wisdom teeth are great accelerators of this problem. So one of the first things I might do is see that there are 8s in place. The number 8 is the wisdom tooth. And think, you know, it's tilted, it's twisted, it's definitely causing an interference. Maybe it's not a tooth that they need. Sometimes the problems have been largely corrected actually by having the wisdom teeth removed, because they've taken something quite tall out of the back of the hinge of the mouth, and that's where a lot of the interference is going, that's actually making the pterygoids sort of work ipsilaterally to do this lateral grinding action, which really what it's trying to do is it's trying to flatten the cusps. Now, in somebody that's got a shallow dentition, they will actually quite easily go bumpity bump, and they will rub over the teeth, and they will start to flatten the teeth. So they give themselves a bit of freedom of movement. But with people that have a deep overbite, and I'm like that, and I think you are as well, Tim, from sort of seeing you smile, we don't really have that freedom of movement at all. So we can't really.
I've noticed that while you've been talking, I've been testing myself and thinking it feels like my teeth are almost.
Yes, you can't do it because you've got a very deep overbite like me, and it will not free itself. It's absolutely trapped. So people like us, instead of grinding, we clench. We are absolutely locked in. So we don't have any freedom of movement to stress break, because that's what the grinding is. It's a good stress breaker. If you're anxious at night, you're having a bad dream, you've gone to bed with a few problems, you will grind worse at a time like that than if you've gone to bed after a lovely hot bath with a glass of whiskey and you've even drunk, beautifully relaxed. So people like
my wife will kill me, but I've seen her doing it at night, and I thought she was dreaming about food. But it's just a stress thing, isn't it? You're not actually imagining eating. But
when my father used to kick my mother in the night, he was dreaming about football, but that's quite different. So we will actually, instead of being able to move anywhere, we will clench up. And we will clench up like a vice, but we might have micro movements within that vice. There might be a micro lateral movement that the lateral and the medial pterygoids can exert. And so what we do is put lateral forces on cusps, and they crack. And the patient starts to exhibit things like, frequently, they're breaking teeth, they're breaking restorations. They haven't particularly got wear facets, but if you look in the mouth, they'll have good teeth at the front perhaps, but they'll have crowns at the back. Why? Their caries rate surely wasn't different from the back than it is at the front, but why have they had so much disruption at the back? Because the chances are, where they've lost cusps and cusps have had to be restored, those were previous interferences which their masticatory system has banged off, they've cracked off. You get, first of all, you get propagating cracks in the teeth. So people will exhibit extreme sensitivity, all-round sensitivity. They can't eat ice cream, you know, oh, don't give me anything cold. My teeth are always so sensitive. And that's because they're getting fine cracks that they can't see. But then those cracks start to propagate. And sometimes people will say, oh, I broke my tooth on the cornflakes this morning, because the damage had finally happened at night, that final bit of cracking, and then they eat the cornflakes in the morning and the cusp comes out. So when you're looking in mouths and you can see that they've got restored teeth, but not just in the center of the tooth, but it's also part of the outer wall of the tooth or the inner wall of the tooth. Something's gone on there. And the chances are, unless they've got rampant caries everywhere, which is tooth decay, it's been a traumatic problem and not necessarily through eating. The odd one could be in a granary bit or something like that, but generally it will be grinding, particularly if there's a pattern of this. And the forces can be so extreme, you can actually split a tooth down the middle and karate chop it into two pieces. And I think every dentist, once or twice a year, will get a patient in who has literally split a tooth in the middle. There's nothing you can do except extract it. There's also acceleration of periodontal disease. I wouldn't expect non-dentists to be able to point that out, but there's a lot of jiggling of the dental support system. So if you combine that with bad oral hygiene, they will actually start to get an acceleration of mobility of the teeth. And another symptom that you will see will be that they maybe have a lot of gum recession. Gum recession happens for a reason. And when you've got a lot of jiggling and forces, lateral forces going on the teeth, it's thought that something called abfraction occurs. And the outer bony plate of bone, the outer plate is very, very chamfered towards the part where the tooth comes out, is very, very thin. And this forward and backward jiggling fractures off fine parts of this lower plate. And then the gum recedes with it. and it recedes again. And then toothbrush abrasion comes in there. So you've got this, the enamel stops, you've got the dentine, which is the softer part of the tooth. So you can wear a channel. But also we know that enamel prisms, that's the structures that the enamel is made of, they have a certain amount of elasticity, teeth do. You wouldn't believe that, but the jaw has elasticity and so do the teeth. But actually, under too much force, these prisms will actually ping off. And so somebody exhibiting sensitivity, a lot of gum recession, a lot of grooves at the neck of the teeth, a lot of wear facets on the teeth. The anterior teeth haven't got a lovely curvature on them, but they've gone flat, or they've even got facets into them, or they've gone completely flat and the centrals are exactly the same length as the laterals. All this is indicative that they've actually been doing parafunctional habits, and those are not really the daytime habits. So
it's really hammering home this point to me, that about these very subtle differences between jaws that end up in very big differences in terms of how the patient experiences life with their teeth, because you can have some little imbalance that over years, that your whole lifetime, 40 years, suddenly causes a problem. And that's really interesting to me. It's a whole different way of thinking about, because I think that non-dentists will think if you develop a problem with your tooth that something probably changed recently, but actually you might have been doing something for years.
oh, absolutely.
Imperfection. So
absolutely. Now, when I got everybody to put their arm in the air, I bet everybody was desperate to get it down. And the reason was,
I don't think they were desperate for my arm to come down. I think they were quite enjoying that.
They were feeling tired in the jaw, in the arm joint, in the shoulder, from holding it up. And why were they feeling tired in that joint? Well, because if you go back to the coat hanger idea, this muscle, the muscles around the joint of the shoulder, are only relaxed when your shoulders are dangling to the side in a relaxed mode. So the moment it's raised like this, you've got contraction and you've got expansion. You've got contralateral muscles working, and they're actually, if you don't move that arm, they are exhibiting a sort of an isotonic contraction, really, and they're building up lactic acid and they're getting very tired. So take that now to the jaw joint. If that jaw joint is not in an ideal position because the teeth bearing anatomy, the interdigitation of the teeth is not allowing it to do so, then we know that, like any other joint in the body, that joint is not in its favored position, where its muscles that are associated with it hold it in a relaxed position. So the moment that jaw joint is in a slightly different, and we can be talking nanometers here, we're talking finite, tiny, immeasurable distances, not a centimeter, but something that's only measurable by electron microscope. But however small, some of those muscles, 1, 2, 3, 4, but more than likely the pterygoids particularly, will be in stretch and contraction. And they're in isotonic stretch and contraction.
I'm just experimenting as I'm speaking on myself and realizing that if I had something sticking out the back, as you bite, you tend to shift slightly forward. And I presume what could be happening is you'd be locking
exactly
in a more occlusion, but you'd be slightly anterior. But that means you're not actually grinding it away. You're just locking closed. And that might be why it persists for years, because you're not actually so quickly grinding the bump. You're just shifting forward and then closing.
Some people, by virtue of the fact that they've had orthodontics even, are now shifted into a position where the maximum interdigitation of the teeth has got the jaw in a shifted forward position. So in fact, some of those muscles are completely in stretch. If you think of the lateral pterygoid, for example, which is onto the condyle head, that has got tension now, both on the capsule, on the head of the condyle, and also on the meniscus itself. And so any muscle that is not relaxed it can be relaxed a little bit more perhaps during the day because you're in freeway space, but any muscle that gets tired like that is more likely to go into spasm. Now, there are millions of people walking around like that all the time. And they have the silent features that I've described before, but they don't necessarily have pain. They may have a click, but it's not painful. They may have crepitus. So they may have a noisy symptom, but they don't have pain. But it's very much also tied up with stress. They are in something called, they're in an adaptive zone. They're in their sort of adaptive capacity. They're working within that adaptive capacity. A body is we are an adaptive species. We can put up with things to a certain degree until all of a sudden, the straw that breaks the camel's back. And this is really going to be the crux of it, because suddenly the loss of a job, coronavirus coming up, and you're running a business and you've had to furlough all your staff. Your wife walks out on you and leaves you with the children. You've got a marriage coming up. Some big life event, something out of the ordinary. All it takes is one extra scenario to happen, and bang, and the symptoms come in. And this is not with somebody that's had toxin. This is just a normal individual. That suddenly, that extra amount of stress pushes people over their adaptive capacity into painful symptoms. And they can be just a bit of mild aching in front of the ear, a bit of tenderness perhaps on one side, or full-blown headache, spasm, jaw ache, and trismus, where the lateral pterygoids actually got them. It's in spasm and it's locked them up. And if they even suffer like that for too long without getting help, and they're in spasm for so long, that lateral pterygoid that's actually joined to the capsule and the meniscus can actually, in the end, bring that meniscus, that disc forward, and actually they can bring it too far down the fossa, and you can get you could either be locked up, or you could even find that it flips forwards and you're locked open. So a major sort of damage to the joint. Indeed, the huge forces of, say, 20 stone per square inch that you can actually put on during clenching, it doesn't just take its force in the teeth and damage the teeth, as we were saying, but actually that load is also directed up onto the articular surface, onto the fossa, and the disc that sits in between can get squeezed, squashed, even perforated. So you start to know when you're getting these problems, because you're getting very tender joint pain in at least one of the ears, and you're more likely to get some crepitus and some noisy symptoms as well. Either you hear a bit of a grating sound, or when you're opening and closing, chewing, the people across the table can actually hear the echo of the click. So really, the crux of all of this is, you've got a car with 4 wheels, and it's smooth, it drives perfectly. It doesn't necessarily mean that you've got a good amount of pressure, air pressure in the tires, but it's functioning, it's driving forwards, it's moving. You as the driver don't realize that your tire pressure's perhaps down, but you're driving fine, and you're not noticing the difference. That is a reasonably well-working system. It's either totally perfectly working like a Grand Prix car where everything's checked to the ultimate degree, or it's just your average car going around town, which has probably got dropped air pressure, but nevertheless it's functioning just the same. One tire bursts, suddenly you have an entire breakdown. You've got problems. You're not going anywhere. If this was the masticatory system, one extra problem: you weaken the masseter muscle. Everything was in a fine balance beforehand, maybe pivotal, because it was just within its adaptive capacity, and the slightest stress would have pushed it outside of that and caused major spasm in the muscles. And you don't realize that you've actually got a hand grenade there, and it's got its pin out, but you're handling it very carefully. And so it doesn't go off until suddenly somebody comes along and starts to weaken one of the muscles by putting some toxin in. it totally breaks the balance that you've managed to hold on to. It spoils that balance, and suddenly you've got symptoms, and that's the problem. And I think
so there's a percentage, this is a really interesting take home, that there's a percentage of people who have a degree of hypertrophy who you then treat, and they may not have symptoms, but then you may shrink the muscle, but you create symptoms because they're now out of balance and they're clenching and they've got pain from other muscles.
that is the worry, because you are interfering with a system that has found a way of working without pain. Mm. And you've actually exacerbated it into, it may not be particularly pain. It could be that it goes into spasm on one side. It could be that you start to cause different pressures and different movement in the disc, which just throws it off balance. And the meniscus itself, in the joint, the disc then starts to be dislodged. So you're opening up a can of worms, really.
Yeah.
So
I think this is one of the key take-homes I'd like people to get, which is you can relax whatever muscle you like in the upper face. They're expression. They're not actually functioning muscles in the way that your masseter is. And if you're upsetting the balance of your masseters, you risk changing a very complicated, finely tuned system, and then causing other problems, which might be solvable by looking at the dental position before you start messing with the muscle, which is a really interesting take home.
I think that probably with the number of masseter injections that are done, and maybe the temporalis and other, even the pterygoid muscles, but I think most commonly the masseter, that a lot of the time people get away with it. If they do upset the system, the patient doesn't realize, because the patient doesn't connect the two. I also would say that the muscles of mastication, particularly with the temporalis being there, they rather overlap and overlock and are adjacent to the muscles where you tend to get tension, headaches in the head and going down the neck and the shoulders. So, for example, it's not unusual that when you've got somebody who's got joint problems, TMJ dysfunction syndrome, which can be painful or non-painful symptoms, any of those symptoms that I've told you about, whether it's symptomatic or not, a lot of those patients, if you ask them the questions, they will suffer with quite a lot of headaches. Some of them will have headaches all the time. Some of them will have more headache than not having a headache. And some of them will have, once or twice a week headaches, and they'll associate those headaches with, oh, well, it was a bad day. I was really, I had a really hard day today and I felt really tense, and, I've been doing a lot of close work, and so I've come home with another of those headaches. Mm-hmm. So it's very difficult to separate the two types, because muscles ricochet. It's like a pack of dominoes, really. You've got a nicely balanced system. You start to press the dominoes over on one end, and before you know it, they've gone right across to the other end. They've all fallen down. They have no sort of clinical evidence as such, but way back when I was learning occlusion, they had sort of mapped muscles and spasm in muscles for when somebody was wearing a splint, and they had got a mimicked perfect working system, which is what this splint basically does. When I actually gave my husband a splint 25 years ago, he used to have terrible back spasm. He thought he had ankylosing spondylitis, but there were no antigens discovered. There were no, he had the blood test done, and nothing was sort of, oh, I think it might have even been before the blood test, but that's right. He didn't have the blood test, but that's what the diagnosis was given. Once I fitted him with a splint, we suddenly realized one day his back problems had completely gone. His spasm had gone. And they actually mapped spasm right down to the calf muscle from getting somebody's masticatory system evened out, mimicked as a smooth working occlusion. Both the neck muscles, the shoulder muscles, the back muscles, trapezius, and if you think about it, all the way down. Now, it can be the other way around. You can actually hurt your back, and muscle spasm can creep back the other way. So it doesn't always start here, and it can start here and go up to the head. It may be that you're frowning an awful lot, so you set up tension here. But think about the types of personalities that we've already talked about, the type A personalities, they're often precision people. They're people that worry and they whittle.
I'm just thinking about a patient that I saw years ago, always stuck with me, who had been, in his words, he'd been everywhere, tried everything, and he had painful headaches from bruxism, and I don't think he mentioned actually the dentist, and also it was early days for me doing aesthetics, but I was aware of it being that you can treat bruxism with botulinum toxin, but he'd been through all the medical routes. And I almost thought, I'm going to see if I can find his name to make sure he's at least seen a dentist, because his life was really hard, and neurology and all those kind of things that happened. I don't know. I wonder if he'd seen a dentist, but it really makes you think, particularly patients with pain. Like, this is complicated. It's not. You've just listed off so many potential causes of the symptoms that you need to think about this much more holistically.
I've had so many patients in the past where they've come in with diagnosed migraine. They have terrible headaches. They are booked in the following week for a CAT scan at the hospital. The results come back. There's nothing wrong there, but nobody can get to the bottom of the pain. And they happen to come in because they've either broken a tooth, or they come in for their normal checkup, and we're talking about the medication that they're on. And we look in the mouth and we say, I have a pretty good idea what's going on here. And we take them down the route of assimilating a perfect occlusion with a splint. And these were pre-toxin days as well. And suddenly they would come in and they'd say, I can't believe it. My headaches, they've gone. This is amazing.
Yeah. I have someone on Instagram that's worth sharing. So Dr. Zainab has said, I've seen severe trapezius spasm, facial neuralgia, all linked with a gold crown that was too high. So that ties in exactly.
Absolutely. Oh, absolutely. Absolutely. And unfortunately, these things are not uncommon in dental practice, because there's a good proportion of dentists, maybe some of the younger ones even coming out, maybe some of the much older ones that have not done the sort of occlusal work. But in a way, iatrogenic problems created by man, even created by the dental work that's been put in, that has created an interference which literally takes them over their adaptive capacity. So I would say, sadly, that dental work can very easily push somebody into full-blown TMDS symptoms, just as likely as an aesthetic doctor can by using toxin in a masseter muscle, let alone a temporalis muscle, or even into the pterygoids, without stabilizing the joint first. And that's where I come on to it, really, that when I see patients, and this is what I would urge to clinicians who are non-dental, that if they are treating the faces for aesthetic reasons, that they first of all identify whether there are a number of these symptoms, because if they're picking up a number of these symptoms as are described, they run the risk of upsetting this fine balance. And they may like to ask, do you suffer with a lot of headaches? Do you get sensitivity of the teeth, for example? Do you have any noise in front of your jaw, or does it click at all? And another one that I didn't mention was, of course, if you actually stand at the front of somebody and ask them to open their mouth, if they've got relatively relaxed muscles, they will be able to open about 4 fingers width. They'll be able to put about 4 fingers worth in between their teeth. If they can't do that and they're too closed up, they're partly exhibiting trismus, which is spasm of the muscle already.
I'm really tempted. I'm sure everyone at home is also trying this. Only 3. I haven't got a very
how
big
big
mouth.
your hands are, I suppose, according to your mouth. So, it's the general rule of thumb, if you'll excuse the pun. Most unfortunate. So not only that, but watch them when they're actually opening the mouth. Because when they open the mouth, if there is spasm in one side or the other, they will not open necessarily in a straight path, but they will do a zigzag. And they will move towards the side of spasm. They may even just move.
This could actually be something an aesthetic practitioner can do in a consultation. Like just ask them to...
Absolutely. Oh, absolutely. Yeah. Yes, quite. And they may, in fact, if they've got spasm on one side, when they open up, they may open up just literally to one side. Now, we mustn't forget that there are some people who, in the morphology, they have got a shorter jaw on one side than the other because it hasn't grown properly on the growth plate. So, you know, there will be people like that who have to open in a curve because they haven't got a perfect horseshoe anyway. We must also remember that there's a small possibility, but they could have a tumor in the joint. That's another thing that could be causing some disruption. You know, we can't blame it completely on the interferences of the teeth, but I should say in a large number of, a huge number of the population, probably the most common factor is the way the teeth are interdigitating, and it is going to be triggered by the teeth themselves. Mm-hmm. So, but you've got to sort of keep an open mind on this. So, crucial questions to ask: that yes, if they are a headache sufferer, if they can't open the mouth very, very wide, if it's starting to move to one side or it's zigzagging and making a bit of a crunching noise as it goes across, these are your little red flags. Refer them to a dentist. Don't touch them. It could be the worst session you ever did, because if you cause the problem, it lands up on your shoulders. And don't assume that actually all dentists are kitted out to deal with the problem, because every dentist has their forte. I didn't do orthodontics. I didn't have any interest in that particularly. So, you know, I would refer on for that. Somebody won't like root canal. Somebody will diagnose occlusion, but they won't necessarily know what to do with it. So it's really a case of getting lined up with a dental practitioner that you do know is interested in occlusion and that will make hard appliances as opposed to soft ones, because soft ones are no good in this situation. And really, those people are better to be fitted with an appliance and have actually, well, they could go, obviously the dentist will look at them one further than that, because they'll perhaps spot an obvious problem. A tooth that's tilted forwards, a wisdom tooth that's in the way, some obvious interference. It may need dealing with in a restorative way anyway. It may need an extraction. But in the absence of all that, at least the dentist then would be in a good position to make an appliance. Mm. And the appliance can either be, sorry.
I was going to, let me just to kind of wrap it up, because we're an hour and 40 in now. If I just try and do a summary of certainly the take homes I've got, which is, don't think about the masseter muscle simply as a muscle that opens and closes your jaw. It's part of an extremely complicated and finely tuned system that if you have an enlarged masseter, there's a good chance that it's because there's an imbalance in the system, and you may not make the system more balanced just by relaxing the muscle. Now you might, but it's going to be luck more than anything, probably. Think about the occlusion, particularly of the rear teeth, and think about the dentistry before you necessarily just relax everyone's masseter muscle. That's what I'm taking from this so far.
One important point from a question that was sent in on your WhatsApp group was, why, when aesthetic practitioners Botox the muscle, does it not last? And why does it come back quickly? Mm-hmm. And of course, the reason being that they've relaxed the muscle, therefore it's atrophied for a while, but the cause for the hypertrophy in the first place is still exactly the same as it was before. So the only way, my patients, I very rarely, I do their toxin, I provide a splint. I do their toxin once, 2 weeks after they're wearing their splint. I review them at 6 weeks. If they need a further reduction, I do a second dose. And I rarely have to touch them thereafter, as long as they're wearing their splint at night. Particularly the one that takes them the premolars and the molars off, and we have a gap. The fact is, if you all just clench together now, if you've got back teeth and you touch your face, you can feel your masseters fire. The fact is, if your mouth is open from number 4 to number 8 and you are together at the front, but you don't get contact at the back, if your molars and premolars don't touch, you can hardly fire that masseter. So in other words, you're not able to parafunction at night, you've reduced it, you've then given them a protection on the teeth to give them a smooth working, and you almost prevented them from firing that masseter again. So the growth again is very slow, and it's really down to not normal function, because we know that that doesn't cause it. It's daytime parafunction that you can't protect against. You can't be wearing a splint all day. It might be that they're a chewing gum chewer. They may be tensing up when they're driving, but those are small periods of time, and it'll cause a very small increase in size. And for the price of a splint, for the cost of a splint, that probably is about the cost of one session of botulinum toxin. So whereas yours might need them every 3 or 4 months ongoing, mine will only need 2 doses right at the beginning with a splint, and apart from changing their life, getting rid of their pain, improving their looks at the same time as well, except you've got to watch on a man, because if a man is exhibiting symptoms like this, you don't want to reduce his face shape too much. It's not as masculine a look. Then they don't often
older
need
women as well. There's
Yeah.
an issue with older women, and they develop
a
fold.
That's right, yes. Well, if they're over 50, of course, you don't want to do it too quickly either, because they haven't, the elasticity of the skin won't recall it back up again, and you might end up with jowls. But no, it's one way of getting the effect to be long lasting. And I've had that with patients where I've seen them, they've been referred to me, I've seen them maybe 2-3 years later, and I say, how are you? How's the pain level? They may have had subjective pain level of 8 out of 10. One of my cases did. 3 years later, she said, I'm absolutely amazing. My jaw, I don't have to hinge it. I don't have to try and open it in the morning. I don't have that noise. I don't have the headaches because I'm doing the upper face Botox at the same time. And it really does make a difference to their lives.
So do you think there's a genetic difference between different faces in terms of causing this problem? Because I was taught right at the beginning that Chinese people are more likely to have this enlarged masseter, and it was just genetic, which now listening to you, I'm thinking, can that even be true? Do they have more dental problems, malocclusion issues? Is it that their muscles are hypertrophy more easily, or is it cultural that they're aware of the shape and they're chasing the aesthetic? And they haven't.
I've tried to read up on this, and it's very, the evidence is very thin on the ground, the supposition, but I've got my own theories on that. The Chinese race, the Asian race, they have much flatter zygoma, flatter faces altogether. Therefore, the morphology of the skull is different. Therefore, the workings of those muscles, wherever they are, their origin and insertion is, it could be that the way they work together gives the masseter a greater advantage to become bigger. They have a different skull shape, so therefore one could assume that maybe the balance of the muscles is different. They also, Chinese, as far as I can think, often have wider jaws and a lot of room for the teeth and much straighter teeth. Now that doesn't necessarily mean just because they're straighter and they may be prettier that they work better. But the chances are they've got room for more wisdom teeth. So perhaps a larger proportion have got the wisdom teeth. And we do know that the wisdom teeth, and if you remember that accessory muscle on the medial pterygoid, maybe they've got more molar interference, particularly wisdom tooth interference. Another thing I know about my assertion, some of the Chinese race, is they can be very driven. A certain, there's a certain part of the population that you see, they really do get to high places. Their entire country is often driven, just having to look at the music side of things with some of their, when they have one child and they drive them to the music. I think they are possibly quite a driven race. So you might have more type A characters in that, more stress. It's a combination of everything. It's multifactorial, and I don't think that there is a written answer. which is maybe what you wanted, but I
No,
am
it's an
using,
interesting thing to think about.
I'm
I
just
don't
using
know.
a bit of
It's one of
common
those.
sense here.
There are lots of things that get said to you in training that just go in unquestioned, and that's one of those for me that that I'm now questioning. Like, is this really? Because it's more complicated than just developing a big muscle for no reason. You've elucidated that really well. So I'm now questioning everything. It could be for all sorts of reasons other than just genetic. So I just wanted to finish really with the sequence that you would go through if you weren't a dentist, and you're a doctor or a nurse, and someone comes in with bruxism or with an enlarged mastoid. They've got no symptoms. Let's pretend they have no symptoms except for the aesthetic. What would you recommend that those non-dental professionals do in that situation? Is there anything they can see that's really accessible that they could explain to the patient? Because it would be better for all of us if we don't just refuse to treat, but we give them a really good reason. So what would your brief story be, or the examination you would do that would give them the sense that they'd seen a real expert who was interested in their well-being?
Firstly, I would put to them that the hypertrophied muscle is hypertrophied for a reason. And that reason, if it's not that they are maybe very bodybuild shape, where they're obviously doing a lot of this sort of gym work where they're pulling down on weights, there may be a good reason like that, or they come in chewing gum. So there may be something during the day that they've got a particular habit. But in the absence of anything noticeable like that, I would point out that this muscle isn't just like that, just by accident. I would have a little assess anyway and ask them the simple questions like, do they get frequent headaches? Are they aware of a lot of tension in the jaw? Ask them to open and close and see whether they have a decent opening and whether it's a straight path of opening. And do they have any noise? Do they have any clicks? Because the moment you see any of those problems, and you may just ask to, I think an aesthetic doctor and nurse should always look behind the lips anyway, because when you're looking at cheek support, if you want to see if they've got molars in there or premolars, because that might be why they're sinking in. If the lips aren't sitting the way they would want, is it because there's an underlying problem? You know, you've got to look, are the centrals poking forwards? If they are, you've got to be very, very careful not to place any material in the lips at that point. You're going to make it worse, you know. Or it might be that the laterals are forwards and the central is back, so that you can afford to put a little in the centre of the lips. So I do believe that aesthetic doctors and nurses should be looking in the mouth anyway, and they do have gloves on. Just ask permission to have a peep inside. Have a look at the level of worn teeth. If you're not familiar with this, go onto the internet and look at dentitions and look at worn dentitions, because there's so many examples there, so that you can start to recognize what these are, and just have a little peep at the back of the mouth and see if you can see heavily restored teeth that are over the sides of the teeth as well. And all these will ring little alarm bells. If the more red flags that you are lifting up, the more I would be loath to treat those patients myself. But I would give them an opening and say, I have got a connection with a restorative dentist, with a dentist that knows about what's going on here. May I suggest that if your own dentist doesn't deal with this, that I send you to this person. They may not use toxin, but of course they may be able to make an appliance. So that's what I would suggest to them. I certainly, if they see these red flags, I wouldn't just barge ahead and ignore them, because you may get away with it on so many occasions, but one of them will come back and bite you. And, you know, it's just not going to be worth it if you've got a medico-legal issue because of that. You know, it's going to become a major headache for you. So I think that's, I suppose the dentist in me ought to say, well, actually, really, it's a dental problem, and it shouldn't really be dealt with by anybody other than somebody in the dental profession. But that's a little bit ideological, because, of course, across the world it will be. So really, the whole point of this is to try and guide the people that you train into seeing where the pitfalls are, which fields have got the mines in them. You know, at the moment you are all walking across a field as if it's just a lovely ploughed field. If suddenly you come to that ploughed field the next day and there's a sign up which says, beware mines, you're going to be a little bit more careful about where you tread across it. And in case one blows up in your face and you end up like you see in these war-torn countries. So that's what I would say. It is a minefield.
Yeah, I can tell you that you have absolutely changed my perspective on it. I've learned so much around the subtlety of it. And as I said to you in our kind of warm-up call, I love finding out that something's a lot more complicated than I thought, because there's a whole lot more to think about. Anyone who's listened to all of this should be able to give their patients a lot more basically expertise about what could be causing the problem. And I hope someone out there avoids repeatedly having Botox that makes things worse, and actually could have their whole problem solved by filing down a tooth. You never know.
Well, absolutely, or even a simple extraction of a wisdom tooth can be a tremendous, that is a very common occurrence actually for creating these problems. And you see it also in people who are trying to erupt wisdom teeth with, partially erupted wisdom teeth. But in our surrounding area where I work in Acomb, at a dental practice, the Acomb Dental and Implant Practice, which is near York, I do have people who send patients to me. They are dentists, but they can recognize the problems, but they don't actually deal with them themselves. So, I think wherever you are in your area, do your homework and find somebody. I'm very happy. People can travel. I've had a GP from Nottingham, for example, who was speaking to me at the airport when we were coming back from Tioxane lab in Geneva, and she had huge masseter muscles. And just a little talk at the airport, and suddenly it just switched her on straight away. And the next thing, she got home and she was on the phone. And
there have been one or two people watching on Instagram who've said something similar, that they've now suddenly realized that some of their, I think you predicted this might happen because it's so common, that people realizing that they have a degree of parafunction, which is interesting. I think we should probably wrap up now because it's just hit the 2-hour mark. I knew you would share an awful lot. We probably should have done it in 2 sessions. But really,
that's what you suggested at first, wasn't it? Yes.
But thank you so much for your time. I really appreciate it. As I said, it's quite rare for me these days to have someone give me a whole bunch of new concepts all at once for me to think about. So I'm really grateful for that.
Well, I'm rather thrilled that actually it's me that's done it. So yes, thank you very much indeed. And thank you very much for inviting me onto your platform. I've enjoyed it very much, and I do hope that it's been useful to your listeners as well. Yeah, I'm absolutely sure it will be to many. There are a few clients coming on as well who've had this treatment, who've also learned something from it. So I'm sure it's going to be doing good work. Thank you very much, everyone who's commented. I'm sorry I can't see you on Instagram. On Facebook. I can see people on Instagram. Berry Dental, I really appreciate your inputs as well. I didn't think you were spamming. I know someone said you were just commenting and sharing your information. So thank you for that. But I appreciate all the engagement. I'll answer some comments, so you can have a look on the Facebook page if you want to have a look on my page. And if there are any questions you can answer that as well. What's your Facebook and Instagram if anyone wants to follow you? My Facebook, it's Ruth Brady. I tend to put a lot on that rather than, I really should be putting it on the business one, which is Dr. Ruth Brady Aesthetics. My Instagram is Dr. _Ruth Brady _aesthetics. I tend to put more things onto that. So not necessarily TMJ related, because a lot of what I put on is not full face pictures. It might be, I've got maybe part of a feature where I'm showing befores and afters, where of course, when you're trying to show a masseter reduction, it really does involve putting the full face of the patient. But I've had some very interesting cases who I am allowed to use in lectures, which is, very kind of them to let me show, and one I won an award with, as a matter of fact, and they are often both areas. They're both masticatory system, not necessarily just the masseters as well, and upper face as well, headaches, because of course it does go hand in hand. But yes, it's a very, very rewarding sort of treatment as well when you diagnose it correctly. You really can change people's lives,
Right.
you know, not just the way they look, and that makes them look better anyway. If somebody feels better, they look better.
Yeah, and that's what it's all about, that's a really good way to finish off. Some good compliments about your analogies as well. I know you put a lot of thought into developing those, and I appreciated them as well. They really help you change your understanding quite quickly. So thank you very much.
I'm sorry I lost my train of thought twice in it, but there's so much going on here that it
was great. Thank you so much.
put it down to age, Tim. Put it down to age, on my part, that is.
Okay. Thank you very much, Ruth.
Thank you very much.
Hopefully we'll do something similar like this again. I appreciate your time.
It'd
And thanks for sharing it.
be my pleasure.
Okay.
Thank you.
Thank you, everyone, for
Bye-bye.
watching. Good night.